go on to the next speaker, and the next speaker is Dr. Shylesh Dabke from Karnataka, Bidar. Okay, great. He'll be talking about incorporated premium IOL in your practice.
Hello, good morning. Today I'm going to be talking on incorporating premium IOL in the practice. When we are talking about premium IOL, we are incorporating a premium IOL. We are talking about a hospital or a ophthalmologist. He is pretty set with the surgical skill, namely the phaco. Does phaco to the best of precision one can do. Not just the precision with the surgery, has got a predictable outcome as well. But mind you, he is doing it mainly only with the monofocal IOLs. And when we are talking about such an incorporation, we are actually talking about a big transition that one gets into his system. Now the question of why to incorporate. We all know presbyopia is a pain. Not everyone would be wanting to walk around with their reading glasses. The age of 60 is the new 50 or maybe 40. People are having a longer active work life. Third one would be incidence of cataract in a younger population is on a rise, probably because of increased incidence of diabetes, trauma, or steroid use. And there has been a wide invasion in the instruments, the gadgets, the screen time. People tend to have an increased need for a intermediate vision. If you look at the question of how to incorporate. So if you look at these ads by Lidl and Colgate, what they are actually doing is they are just not directly selling the product. They are wanting the customer, having a want or generating a need in it, generating an emotional response. So selling a premium IOL, you need to generate an emotional response. Patient tends to buy premium IOL on emotion and justify their purchase by fact. So you should be talking mainly about the benefits of the IOL rather than the features. So that's one point. Other thing is on whom to incorporate in. If you get image of this particular character of Nana Partekar from this movie, and when you see a tentative premium IOL patient walking in, it would be a good red flag. It would be a good, good no-no not to incorporate in such type of personalities. They are going to bug your life for the rest of your life. So pick your patients wisely. Have a look at the personality of the patient who is walking in. You do not want a fuzzy kitty party going auntie who wants every part of your hospital to be sterilized before you actually touch her. Better not touch her. Look about the laterality of the cataract. You do not want to implant a premium multi or a trifocal IOL in a young patient with a unilateral cataract. Look closely at the occupation of the patient. Drivers and patients with fine arts are not ideal candidates. Look into the affordability factor as well. It is important to set a realistic expectation to the patient. Always under promise and over deliver when it comes to premium IOLs. And look closely for what the patient wants. Patient might be just fine with a good distance vision or maybe fine with using readers. So once you've done it all, do not bombard patient with all the plethora of the options that are available when it comes to premium IOLs or premium cataract surgery. You need to individualize IOL selection. There is no one size fit all. Figure out what patient might be a candidate for first and then make a strong recommendation based on that, rather than making a list of recommendations, then figuring out whether the patient is an ideal candidate for the same and also if he or she can pay for the same. It's always a good practice to have a lifestyle vision questionnaire so that you better understand the visual need of the patient and suggest appropriate IOL based on that. When we are looking at the IOL formulas, how well are we performing or hitting the target? The target eumetropia with third generations, we are there by 78%. With fourth generation, we are there by 90%. What is an IOL formula? IOL formula is simply a arithmetic measurement based on certain measurements, which takes into consideration certain parameters. One of the parameters is the axial length. The good old debate of A scan versus the optical biometer. A premium IOL, it is always advisable to have an optical biometer, but a correctly done immersion A scan will also do. Next component of IOL power calculation is the keratometry. When we are talking about the keratometry, we are talking about the enigmatic cornea. Various measurement modalities are available for the measurement of the same. Pointers on keratometry would be to look onto the posterior corneal astigmatism, as concentrating only on the anterior will bring about you tend to overcorrect the with the rule astigmatisms and undercorrect the against the rule ones. more the data from more the measurement data that are available with you with different modalities, the better is it to narrow it down for the correct axis and the magnitude of the astigmatism. Look for irregularities of the cornea. Patients with irregular cornea is not an ideal candidate for the premium IOLs. Always measure both eye and look for symmetry. Any asymmetry in these data by these values, you need to redo the measurements again. Third component of the IOL formula is the effective lens position. Effective lens position is basically where your IOL is going to sit into the eye. A more anterior ELP would result in a lower IOL power, and a more posterior effective lens position will result in a higher powered IOL. Most of the formulas perform well in normal eyes. The challenge comes when you are dealing with eyes with extreme axial length or the keratometer, as longer eyes tends to have a lower powered IOL. So even if you are little off with your ELP, you are fine, less of an impact on the outcome. But when it comes to shorter eyes with a higher powered IOL, it's a challenge, as a small change in the effective lens position or IOL power brings about a big refractive surprise. So with the newer formulas with more variables incorporated onto it, we are more there closer to predicting the effective lens position and hitting that target postoperative refraction, the emmetropia that we are aiming at. Coming to toric IOLs, almost all the companies have got their toric IOL calculators in. Just feed in the data, get the power of your IOL and the axis to be placed. The question of threshold for toric IOL, you can't just say I'm going to implant a toric IOL in everyone with more than 0.75 or 1 diopter of an astigmatism. You need to get your data in, incorporate those in your calculators, and ascertain whether the patient actually needs a toric IOL. I'm not going to go into the markings of the toric. Some few of the pointers on the toric IOL would be, one last nudge or a tap on the IOL before closing and patching eye for an hour. What this one last tap on the IOL with the irrigating cannula after having hydrated the wound does is, it ensures a good overlap, apposition of the optic against the PC, reducing the possibility or chances of rotation. In most of the cases, when the toric IOL tends to, go off the intended axis where you have placed it, it usually does in the initial 1 to 2 hours in the postoperative period. Patching off an eye at that point probably would help negating it to some extent. Other thing about the toric IOLs is toric threshold. In case of a multifocal IOL is low, you need to correct even the smaller amount of astigmatism when it comes to multifocal IOLs. Then otherwise you wouldn't want to correct in case of a monofocal probably. Other important factors, all said and done, no replacement for a good clinical examination, right from ocular surface to all the way to the retina, dry eye evaluation, the meibomian gland dysfunction, the endothelial integrity. Other important point would be to look at the pupil size. A smaller sized pupil would sort of cut off the near correcting effect of a multifocal or trifocal IOL to some extent. Yeah. A larger sized pupil will cause more of a dysphotopsia, so better to be avoided in such a case. If you got access to eye trace, look into the angle alphas, the aberrations that are there. Look closely for presence of glaucoma or any macular pathology, as they are going to compromise vision in case of specifically in case of a trifocal or multifocal IOL. Coming to glare, halos and starbursts, these are the dysphotopsia problem that are associated mainly with the trifocals and the multifocals. Less of a problem with CRV and EDOF lenses. We need to, when you are talking about these dysphotopsias, it's better to mention a point about the neuroadaptation that patient is going to have, which may take 3 months to 1 year of a duration. So to conclude, all these measurements would be needed to get a good post-operative refractive outcome in case of a premium IOL. If you miss out on 1 or 2 of these not so significant one, you are good to go. You may have a good result, but that 1 or 2 patient who is not happy with you for having not done this test makes the difference. To conclude, a good post-operative, sort of premium IOL practice our post-operative outcome is directly proportional to preoperative chair time that you give, easygoing nature of the patient in case of a hyperops, and is inversely proportional to preoperative expectation cost of surgery and the extent to which the patient is internet savvy. Thank you.
Thank you, Dr. Shylesh, for the nice